Thank you so much for the opportunity to be with you and just really share how healthcare sharing ministries and Liberty Health Share particularly can fit into the intersection between ourselves and direct primary care. I'm delighted to just make a few introductory remarks to that effect and then just spend some time in question and answer. Well, first, a little bit about the history and progression of myself and healthcare sharing and Liberty Health Share in particular. I've been essentially a healthcare administrator for about the last 30 years, largely in the arena of administering self-funded employer plans. And in especially working with employers and assisting them to minimize and contain expenses. It became obvious to me that there are some fundamental flaws in our current healthcare system at large that need to be addressed and pondered over and thought about as to how to change and potentially resist. The biggest issue that I came to realize that exists and to respond to is how to overcome and react to the issue of the third-party pay system. That is, a system where I, as an individual, pre-fund or finance my healthcare costs and send away a premium to a third-party company, which now becomes their money, and they begin to make decisions and choices about the care of my health. Now, that produces some really significant issues. The first is I really lose a major portion of my individual autonomy about the care of my health because now there's a third-party decider making choices and decisions about the care that I can access or need to seek out or find a benefit for in terms of the care of my health. That is, in fact, Ralph Weber has coined a phenomenal term, the founder of MediBid. He calls them medicrats. That is, those who intersect between medical care and the bureaucracy and begin making choices and decisions about my health. That's a problem, particularly because if we truly are creatures of God, created by God with value and significance and rights, to hand over those kinds of choices and decisions to a third party is truly problematic. That's number one. And then number two is because now it's their money. They're making decisions and choices about a process or a procedure, a care plan that they approve and that they permit. They not only are in charge of the costs, but they're also in charge of my care. And that third-party payment system has produced lethargy, malaise, and total insulation from the costs of healthcare. That is, if they're paying the costs, it's not coming from my pocket, it's now coming from a third-party pay company's pockets, and I don't know about the costs. I never even see a bill. I don't engage with that payer. I have no incentive to minimize expense. No wonder we see just runaway costs in the arena of healthcare insurance and healthcare expense because I have no incentive as a patient to participate in that cost containment because it's somebody else's money. I know about my copays, I know about my deductibles. Once I reach those levels, now it's the insurance company's money, and I have no motivation whatsoever to control those costs because it's somebody else's bill. As a consequence, we've seen those kinds of skyrocketing inflations and pressure to find other options and alternatives in meeting health care costs. But that's a problem. That's a significant flaw. But there's that third-party pay system that is the payer of my health care costs, but there's an additional flaw that I encountered in my role as a health care administrator, and that is what I just simply came to call the sick care system. That is the economic model by which the vast majority of doctors and hospitals were paid on a fee basis, is that they were engaged with that patient because of an illness or a sickness. And they got paid because the more frequently I was seen, or the more frequently they were able to have me come to the office, that's how they received their payment. And they were addressing my illness, not my overall health. And so in that particular arena or system of really not health care, but rather sick care, the motivation on the part of the provider is to just simply treat a disease or an illness and not think about the big picture of my health, how to be preventative, how to be motivational towards how to address my health care needs in the big picture. So I have no skin in the game financially. I'm only being addressed because of my illness. How do we counteract those particular influences in the arena of healthcare today? And so we've begun to take a look at those two issues and counteract them, particularly through healthcare sharing. Now, there's really only, we've been told, possibly for a generation or more, that there's only one way to meet healthcare costs, and that's through insurance. But we also know there is a second way, and that's to be a self-pay patient. That is to shed that relationship with the third-party payer and just simply pay my costs out of my pocket. There's a great to be said for that. Number one, now I really do have financial skin in the game. Now I really am engaged in those costs to ask about treatment, to ask about expenses, because it's coming from my pocket. I truly am incentivized now to control costs. It also benefits by reestablishing the patient-doctor relationship because it's coming from my pocket. Now I really can focus on the kind of relationship I'm building with my care provider and my doctor and healthcare team and arrangement. So now it's not about simply treating illness, which is in fact an upside down paradigm. But I now break through that by paying it out of my own pocket. The problem, obviously, with that is what happens when I have catastrophic expenses. What occurs then whenever I encounter costs that are unexpected and unaffordable, that are beyond my means. And that's really the combination of healthcare sharing. It's men and women coming together on a self-pay patient basis, but sharing their health care costs in a like-minded community of faith and values where my money every month goes to another person who has medical expenses. And I engage in that community relationship, so not only am I a self-pay patient with all of the benefits of having engagement on costs and certainly breaking through the barriers with my caregivers so that it's truly restored in terms of that doctor-patient relationship, but I also have the support community nationally to assist with those costs that are beyond my ability to pay. We call them burdens, healthcare cost burdens that I'm not able to meet on my own. And so that's really how healthcare sharing was birthed. In fact, with the passage of the Affordable Care Act, it really caused me to rethink the way in which we both access for health care and pay for it. I remember well that particular day in 2010. I was getting ready to go to the office, and as I went to my healthcare administration business, and I was getting ready for the office that morning, I saw the passage of the ACA. It hit me, frankly, like a ton of bricks. An insight that's actually said to myself, I said to myself, there's got to be a way for the average, ordinary American not only to pay and meet health care costs, but to do so without the intrusion of the federal government in a way that we've never, frankly, seen before in the history of our fair republic. And so that really focused my attention on the fact that there's really two crises in healthcare. One, we are all familiar with the crisis of cost and the runaway expenses as a result of the third party's pay system. But there is really a second crisis, and it's the crisis of conscience. Never before have we seen the federal government so intrude upon personal choices in healthcare so that my dollars are being used in ways that I would never permit or never allow or never ask to be used in that fashion. We're all familiar with the Little Sisters of the Poor, Hobby Lobby case, Conestoga Wood, where others have spent countless dollars, hundreds and if not millions of dollars and time and effort to protect their conscience rights in the arena of healthcare. And so I was highly motivated to find a way to achieve that on an individual basis. And so in the early, or right after the passage of the Affordable Care Act, I launched Liberty Health Share as a way for people everywhere across the nation to join in and make health care sharing available and affordable for all. We're a relaunch, a reorganization of an existing health care sharing ministry that's been in place since 1995. They were a small Mennonite group sharing medical bills with a few families who turned to me and said, we really want to take this tradition of caring for one another and meeting each other's needs and burdens and paying expenses, but make it available and affordable for the nation to come to join us on this premise and on this basis. And so we launched Liberty Health Share right after soon after the passage of the Affordable Care Act. And it has been an incredible opportunity and experience to see people come together on that basis. Obviously, as self-pay patients, we experience that reality of an unfair billing system transpiring in American healthcare today that overbills and is egregious. Many of you have probably experienced it. We do almost on a daily basis, that whenever we're at a particular counter asking for a service and they discover it's not being sent as a bill to an insurance company, suddenly those costs come tumbling down on a cash pay or self-pay patient basis. 60% less, 40% less. And so we experience that on a regular basis as a group of self-pay patients, and sharing those costs then on that cost-efficient approach. But secondly, also protecting conscience. Our dollars, our money, does not go to conscience-busting expenses and costs, such as abortion, being the most egregious example, or abortifacients, or sex change operations, or physician-assisted suicide, and those kinds of costs that have been mandated through the Affordable Care Act, being exempt from the ACA, both its fines for not having insurance and its mandates that have become, in many cases, so onerous. And so as a group, we have grown from that first member when we launched in 2012, now to 100,000 households, 240,000 members and individuals in all 50 states. across the country without limitation or barriers, and continuing to add 2,000 and 3,000 new families every month. And it works simply. It's very simple. We simply ask our members to set aside what we call a share amount, a predetermined share amount every month. That money goes into a secure online account. We call it our share box. And through our proprietary online technology, those dollars get matched to another member who has medical bills. And so transparently and openly, you see your dollars flow from your account to theirs. You can message them with cheer, with encouragement, with prayer, and like a true social community, stand with one another, sometimes through the biggest crises of our lives. We constantly receive input and feedback from our members as to the impact and significance of having that sense of community across the nation. And it adds such significance and value to dollars that previously were being sent to the company black hole somewhere, now being turned into an investment in the life of another individual that I see where those dollars go every month. And so we've expanded and grown across the nation and are grateful for this opportunity to really provide an alternative means for meeting health care costs and being focused on the issues surrounding the care of our health. Now, there are some ways in which we have chosen to intersect with the direct primary care movement, of which I'm grateful to be with you here. I know that we are compatible in many of the thoughts that I've just shared about the reason why healthcare sharing is so essential and needed in today's healthcare world. And I'm glad to pursue and express and be a part of bringing about solutions in meeting healthcare costs together, right?
All right, how we doing? You hear me on the, oh, there we go. Got myself powered up. All right, thanks, Dale. That's a great talk. Very much obliged. So what we're going to do for the Q&A segment here, as many of you know, in addition to this big meeting that the foundation does every year, we're doing work every week, and one of the things that we do is the Doctor's Lounge radio show that I do with Dr. Hal, that you all know. And so we're into our 5th year. Very grateful and very happy to be doing that. So the Q&A segment here is going to be a segment on the show. So please bring your questions to the microphone. I've got a few here to fill the space if needed, but questions from the audience are far better than questions from the host. When we start here, I'm going to say welcome to the Doctor's Lounge, and I would like you to make your presence known by putting your hands together. So 3, 2, 1, welcome to the Doctor's Lounge. All right, thanks very much. I'm Dr. Mike Karuchak, your host, with Dr. Hal, my co-host here in the house. And we have distinguished guest, Mr. Dale Burris, the founder of Liberty Health Share Ministries. So Dale, as we discussed beforehand, for the listeners who didn't have the benefit of your talk, give us a sort of a 90-second thumbnail sketch of what Liberty Health Sharing Ministries is about.
We are a nationwide healthcare sharing ministry, a nonprofit organization of men, women, and families who all unite around the common purpose of paying each other's medical bills. And we do that without the help of an insurance company or the government, just a regular, systematic way to meet healthcare costs in a like-minded community of faith and values, where my money every month, Mike, goes to another person, and then should I have expense, that same group is there to help pay my bills.
That's fantastic. Let's. We already have people at the microphone for questions, so go ahead.
Yeah, hi, I'm Dr. Chad Savage. Actually, more of a comment than a question. I'm a member of a health sharing ministry, and one of the things that's so unique about it is you had mentioned earlier about messaging to people who are sick. And my family actually, once a month when we pay our membership, we actually send a get well card. And it's become essentially teaching my children a charitable aspect of it. And I'll tell you, that's a lot different than paying an insurance company premium, and also something I never ever received from Blue Cross Blue Shield, but I get regularly from is thank you letters.
Yeah.
I've never had a thank you letter from paying a premium, but that's my 2 cents. Thank you.
Good. I'm grateful for that. We accomplished that through our online technology, where we're messaging one another electronically through what we call our share box, where literally we are messaging one another with those words of cheer and encouragement and prayer and get well wishes. And so rather than doing it through the mail, we've chosen to do it that way, but it accomplishes that sense of connectivity and support and community engagement with one another.
Okay, introduce
Hi.
yourself and let us know what's on your mind.
My name is Tammy Waters. I'm from Apex, the Raleigh area of North Carolina. I have a number of families who would love to take part in what you have to offer with the health sharing ministries, but they have children with asthma, which is a pre-existing condition. I have one in particular who was hospitalized in the ICU within the last year, and they're very afraid to go take that leap to be on the health share because of the pre-existing condition and no coverage of that. And what would you recommend for those families, because they can't do the health share at the same time as a medical plan, regular insurance plan? So how do they get onto your program and still have that coverage for their children?
In fact, that's a frequently asked question, Mike.
Indeed, we kind of talked about that ahead of time, so perfect segue.
Sure, about pre-existing conditions. Particularly for those conditions that are chronic, as you've just described, enrolling with and participating in direct primary care is an ideal combination with healthcare sharing, so that they're seeking out care for those chronic conditions that may be low cost. And that they can certainly care for through enrollment with a direct primary care. But we deal with pre-existing conditions primarily in 2 ways. As we're all familiar, the ACA has a mechanism for pre-existing conditions, and that's the open enrollment period, where everyone's funneled into an enrollment or making changes in a particular period in the year. Folks can join us any month in the course of the year. They're not limited to participation with Liberty Health Share and Healthcare Sharing, so any month in the course of the year they can participate. Our mechanism is that in the first year, we don't share in pre-existing costs or conditions. So they go through that first year, and that's how it would be particularly useful in the case you've just described. And then we pick up and begin to share in those costs going forward, so that within 3 years it's no longer considered pre-existing, and we continue on. That's number one. Number two, though, is the most beneficial, I think, the most impactful way that we deal with pre-existings, particularly for those chronic conditions that are responsive to a lifestyle change. And you'll agree with me, there's an epidemic of them in America today. High blood pressure, heart disease, certainly type 2 diabetes, obesity, smoking, high cholesterol. All of those conditions are responsive to the way I eat and sleep and exercise and live and reduce stress, etc. And so we welcome folks with those conditions to come join us. And we enroll them in what we call Health Track. A program, we assign them a health coach. They set their own predetermined treatment plan and goals, and with the support of that health track coach, make changes to their lifestyle and progress toward those goals. And we're really seeing transformation take place in people's lives. We share in the costs associated with that pre-existing condition, so long as they're working that program that we call a health track. Once they reach those goals, it costs, by the way, an additional $80 a month, which is largely a pass-through for the health coach. But once they reach those goals, they graduate from the program, the $80 drops off, they continue as a member, and we're really seeing transformation occur in people's lives.
So in the family that I mentioned, the children with asthma, would you recommend that they pay for the Liberty Health Share in addition to an ACA plan for 2 years? Is that
well,
is
it
that
would
what
be
I'm
for the
understanding?
first year, number one.
First year, okay.
But yes, in fact, we are looking for that kind of coordination, cooperation. with particularly chronic conditions being treated in the direct primary care arena so that they have primary care addressing it, and then when that first year expires, we begin sharing in those costs outside of, in that case, the DPC treatment arena.
Okay, thank you.
Go ahead.
Hi, Dr. Tiffany Blythe from Kansas City. I have been on the direct primary care scene about 1.5 years now, and that was the first time that I had learned about health sharing ministries and was ecstatic to hear that this was an option. I felt like it was such a great tool to use for cost savings and all those great reasons that we already talked about. But my experience, especially with Liberty Healthcare, has been not 100% clear or positive, and so I was hoping you could help me navigate that a little bit.
Okay.
So my concerns are two-pronged. One is that there have been some grumblings about maybe some financial instability, some bills that were submitted for reimbursement got denied that they didn't think should have been denied. And sort of along those same lines, I know that Liberty Health Share is growing and changing, but during that growth and change phase, I feel like the role of direct primary care has gotten quite confused. And even in the last 15 months that I've been trying to interact with Liberty Health Share, I think the way that I was asked or told that that would work has changed probably 3 or 4 times. And so I have a hard time even communicating to my patients what the product is, how it would work, how much it would cost them. Can you address that and help me
Well, I
clarify?
appreciate the opportunity to address it. We launched a pilot for Liberty Health Share members in direct primary care about 2 to 3 years ago, and saw the need, the necessity for altering and changing the way in which, because we wanted to incentivize our members to enroll with direct primary care, and saw that because we share in wellness visits, we share in costs associated with maintenance of health. We wanted to take a portion of those dollars and help reinforce the choice of a member and share in the access costs for direct primary care. And so we first directed that as payments to the DPC practice themselves. We found some problems and misuse and et cetera of that sort of system, simply changed it so that the patient, as basically is our philosophy, as self-pay patients, we're responsible for our care and those costs. We just choose to share those expenses in community with each other. Put the member in the driver's seat in terms of their direct relationship with you as direct primary care. And then it's their responsibility to submit those receipts, as it were, to us to share in a portion of those. We have what we call an annual unshared amount. And so a portion of those costs would go towards that. And we would share up to 75% of that family's costs for accessing a direct primary care practice based upon certain criteria as to what is the focus of the practice that they're enrolling in. And so that may be some of the confusion around just exactly getting the criteria associated with reimbursement of access fees and what are the particular, the focus of the practice that you've obviously created. So that's been our transition, and we're wanting to be both responsive to our members and responsive to you. As to how best to craft that.
Okay, thank you.
Let's go over to the other microphone. Go ahead.
Sure, thank you. Patrick Roll, Lancaster, Pennsylvania. We're approaching our 3rd anniversary being a DPC practice there in Lancaster. A little over 1,100 patients, fully 40% of them are members of a sharing plan. And sharing plans are making a killing in PA. There's, to use that word again, killing. So Samaritan, Christian Healthcare Ministries, Medishare are just, they have a big market share. And I've been waiting for 3 years for Liberty to come into PA. So the question is, what is the problem with my state? And what can we doctors do to help you come into PA?
Yeah. We have members in Pennsylvania, and we operate there. At present, because of some questions that were presented to us by the Department of Insurance there, they have a safe harbor law, we refer to it. It's a statute that defines healthcare sharing. They've asked us to hold off adding members in Pennsylvania until we resolve some of those concerns with them, which we're happy to do, and we welcome the oversight of those proper authorities. We're in really the final stages of that resolution, and we'll be blowing and going in 2019 is my prediction. But for now, that's our status in PA, and we're wanting to be responsive to that.
Okay, go ahead.
Hi, Dr. Steve Baker from Vancouver, Washington. DPC practice open for 3 months. I wonder if you could unpack a little bit, please, what the conditions you're looking for in a DPC practice in order for your members to be reimbursed?
Sure. It's essentially three things that we're looking for in terms of direct primary care participation. One is which most every DPC does, and that is same-day access to primary care. The second is particularly cost containment measures regarding referrals out of the DPC to other specialties. That's really key. And the third is cost containment or cost controls as it relates to pharmacy and expenses such as labs and other costs associated with that. So with DPC practices that give focus to those kinds of cost controls for their members and patients, we reimburse that family up to 75% of the cost of access.
All right, well, the audience, oh, no, we still have one more. Absolutely, go ahead.
Hi, my name is Andrea Wadley. I'm a pediatrician in Texas. My family is a member of Liberty as well. So for pediatricians doing direct primary care, a great barrier is vaccines. How do you guys handle vaccine costs for your members?
We share in vaccination costs, particularly in the first year of a child's life. So those wellness visits and vaccinations in the first year of life are a part of eligible costs that we share in.
Okay, thank you.
Sure.
Go ahead.
Hi, I'm Amber Beckenhauer. I'm in Nebraska. I have a direct primary care we opened in February. And just to help some people out, I was talking with a partner, a friend of mine in the back, and I know a little bit of apprehension about a health sharing plan. I'm sure you hear that a lot. We had been recommended to try this from another DPC doc, and we're only on the plan about, I'd say 70 days or a little more, and I was playing in an alumni basketball tournament and tore my ACL. And Liberty Health Share paid for, after my $1,500 deductible, my cadaver graft, the whole surgery, and everything. And so it really works. It's really great. And I just wanted to say thank you.
Well, thank you.
Nice.
Let me add in terms of the question regarding our expectations of direct primary care practices for our members. One of the things that we truly rely on for you is your focus on the health of our members. That is, breaking out of this mode, as I expressed earlier, the sick care model. How better to push against that perspective or that movement in America than in the environment of direct primary care. And so that's one of the issues that we really rely on you in terms of focus on the large picture of adding value and significance and support to the health of our members, number one. Number two is really informing them, in this case, of how to go about keeping track of their DPC fees, their access costs, et cetera, and submitting them for us to share. And for you then, as a DPC practice, to enroll or enlist with Liberty Health Share as what we call an accepting provider. There's a specific email address that's been set up, and I'm going to ask Lori Pierce. Where are you, Lori? Just stand up. She's our VP of Medical Services. Be sure and connect with her while we're here together. But there's a specific email address, goes directly to Lori, dpc@libertyhealthshare.org. It's a way for you as a DPC practice to register with us. You agree to accept Liberty Health Share members. We agree to inform the geographic area around you as to your availability to Liberty Health Share members. And so we see that as a reciprocal partnership relationship and love to do it.
Dr. Lee Gross of the Docs for Patient Care Foundation. Question, you've obviously seen the data now, and you know your patients that see DPC doctors versus patients that see traditional doctors. From your perspective, do you see downstream savings in the patient that chooses the DPC practice, and can you maybe give an estimate as to how much savings that you typically see on the plan side?
Lori would be way better to answer that question than I, but we are just really in the first full year of collecting that data. And as you know from national data, it's the second year and following is when you really begin to see return and savings. And so while our initial analysis shows lower cost with those families participating in DPC, we're not yet sure that data is mature enough to really relay in terms of those percentage of costs that we would project long term. But we're gathering that data, analyzing it, and more to come.
Thank you.
Sure.
Go ahead.
Oliver Braun from Phoenix DPC in Savannah, Georgia, 18 months in business. I would like you to elaborate on those 3 measures that you said. I mean, same-day access is easy to prove for a DPC practice to be eligible to become, for the patient to get the 75% reimbursement.
Yeah.
But how do you size up a practice for cost containment measures or the cost containment measures in pharmaceuticals?
Well, we let the member feed back to us whether or not that particular practice meets those 3 criteria. So we're not trying to certify DPC practices. We've really left that into the hands of the individual member to inquire and discover what those best parameters are and whether you're dispensing pharmaceuticals at your particular location.
Okay, thank you.
Yeah.
Well, that kind of segues into my question or my comment. I'm Shelley Wrench with Employer Healthcare Savings. We currently do DPC for employers, and now we're opening up to do DPC to the membership of Liberty Health Share, as you know. And the one thing that is the biggest gorilla in my room, because I also have another hat that I'm an administrator at a cancer center, are specialty pharmacies and PBMs. We've heard about it all day long. And so what I like about Liberty Health Share, the first time I signed up myself for Liberty Health Share, I was kind of just searching around the website and stumbled on your verbiage talking about generic medications. And I love that you actually put that out to the patients to have the knowledge that they can tell their healthcare provider or their primary care, I don't want the brand name, I want a generic. It's the same thing. The FDA would not have approved it otherwise. So I appreciate the information and giving us the confidence to push back against those that want to prescribe those high-dollar medications.
Thank you, Shelley. Let me just address how we share in pharmacy costs, because that's really the focus of that. And that is, we share in those, we don't share in maintenance meds. But we do provide our members with a discount pharmacy card that they can seek out the best costs for those maintenance medications. Just as an example, I'm a type 2 diabetic. I take a medication every month, costs me about $24. I seek out those generics. It's coming from my pocket. And so we want to incentivize our members to really price shop. when it comes to pharmacy. The second way is that when it's with a doctor visit or a hospital stay, we share in those expenses above $50. So the first 50 is the cost out of the members' pockets, and then above that it becomes a cost-sharing prospect, and so we'll share in those pharmacy costs above $50.
Thank you.
Thank you.
Okay, the audience microphones are vacant for the moment, but anybody who thinks of a question, please come up. I'm going to throw one in here myself. This is kind of a devil's advocate question that we kind of talked about ahead of time, but if your group is a group that takes money from everybody and then puts it into a pot and pays expenses, you know, one might argue that insurance does the same thing. They collect premiums from everybody, they put it in a pot, and then they use that pot to pay the members' health care expenses. So to that kind of an outlook, how do you respond and say that you're not the same as insurance?
Twofold, well, maybe three. Number one, we're cooperative and voluntary, so that there's no contracts of indemnity between members or between Liberty Health Share. Secondly, those dollars are matched with other members who have medical bills. So when you submit your monthly share amount, that amount is then being directed to another person. It doesn't go to Liberty Health Share, to the company. It rather goes to an individual member, and we operate, by the way, on a $24 admin expense. So out of that share amount, $529 for a family, $24 of that drops off. That's how we pay our bills. The rest is then matched to another member. And third is, legally, we are all in that self-pay category. We're nothing more than a collection of self-pay patients responsible for our care, responsible for our costs. We just choose to share those expenses in that like-minded community of faith and values based upon our shared guidelines, we call them. There's a set of guidelines we agree upon as a membership. These are the kinds of bills that we'll participate in.
Good deal. Last question from the audience. Go ahead.
Hey, Phil Hellman. I run a DPC in Michigan called Paradox Health. I'm a member. I think Liberty is great. My question for you, I get this from a lot of patients that I recommend Liberty to, which is how soon can I start getting that rebate for being a member of your DPC practice? When they call and they talk to whoever it is on the phone, they get very mixed messages, and most of the time the people that they talk with just don't know.
Well, again, we've been going through that pilot project perspective, but at present, as soon as they submit that as an individual member, then it becomes eligible for sharing, and it goes through that cycle and process right back out. What we've discovered, interestingly, is that many of those members collect a number of months of that access fee, submit them all at once, etc. And so it just varies by member, but those are immediately eligible when they send them in. There's a technology in their share box for member-submitted bills. They just simply scan the bill, take a picture of it, submit it, and it's immediately eligible.
All right, fantastic. I think we've, too bad we don't have anybody from Guinness here. We've created the world's largest doctor's lounge at about 375 people. So thanks very much. Give it up for Dale Bellis. Wonderful talk.
Thank you.